one mistake, it's a high risk because you have so little sample and so few cells. So for that reason, it's a higher risk that something can go wrong, because if you just make a small error and you cannot use your result, you cannot repeat it. So sometimes we have risks for assay that are, important to us, even though they might not be mentioned in the EU regulatory guidelines for regulations, for example. A type of risk also is interferences. When anti-CD20 or anti-CD38, for example, is used. But interferences as such is, of course, listed in a separate entry in the validation documentation. And it's all about whatever the risk that we have identified, it's all about how we mitigate it. So what type of processes do we put in place to mitigate, to try to not make this actually happen? Now we're probably at the point where we have stated the reason for why we have the assay, we've said something about how we design the assay, we've talked about traceability, and we've talked about risk. And as a final entry at this stage, we need to consider what is the acceptance criteria. So, for example, I think this is an example from our plasma cell screen validation. And the acceptance criteria we had for our plasma cell assay was that it needed to be 100% in agreement with our previous assay. And it also needed to have 100% agreement with presence on bone marrow aspirate morphology plasma cells and trephine, except for non-representative bone marrow aspirate. And we also needed to have satisfactory result in our EQA, the UK NICAS MRD for plasma cell myeloma by flow cytometry. We also wanted to say how well we should be able to detect measurable residual disease, So we wanted to reach 0.001 wherever it was possible to collect at least 2 million singlet events. So that was our acceptance criteria for the detection capability. We also had one for precision, where we wanted CVs of less than 10% if you have a higher level of plasma cells, and less or equal to 20% if you have very, very few plasma cells. We wanted a certain stability of the bone marrow so that we could carry out this assay on a 48-hour-old sample. And we didn't have any strict criteria for the clinical specificity and sensitivity because the clinics did not specify to us exactly what they wanted. So that's just an example from the plasma cell screen. As we then have this section around development and optimization in the template, we talk about the volume of sample to use, and we state very in detail what the SOP is, how we process the sample. I think it's worthwhile to mention about the sample volume used. We try to consider what our cell recovery is. So again, for the plasma cell screen, for example, we find that with the intracellular labeling technique, the cell recovery often is less, and so we need to adjust the volume that we use to make sure that we have enough cells at the end of it. So these are all quite obvious things maybe, but it's just recalling to include all this in the validation documentation. And if you have more than one matrix, meaning the assay is to be used on peripheral blood, but also on fine needle aspirates from a lymph node, for example. Is the volume used always the same? Is the processing used always the same? No, it's not in our lab at least. So if I do a kappa lambda B-cell clonality check in a peripheral blood, I will carry out red cell lysis. But if I have a fine needle aspirate for B-cell kappa lambda and B-cell evaluation, I have so few red cells, I do not need to lyse the red cells. So again, small details, it just needs to be captured and thought through. So, one of my favourite entries in the validation template that I feel is one of the more clearly useful tables for the ongoing use of the assay and for when we train new staff and even old staff is the list of internal controls. So for every antigen in the assay, and this is an example from the monocytosis assay again, we state which population in the sample is our internal negative control and which population in the sample is our internal positive control for each and every sample. And then we have figures that show exactly how we do the gating, the routine gating that we do, and if it's quite common that we need to do a patient-specific gating, we will state that we have to do that and why we have to do that. But of course, we can't show a picture for every possible different patient-specific gating you have to do. This example is easy because it's a monocytosis assay and it has a very simple gating that is the same virtually for everybody. And in the same area of the validation template, we also state all the details about the reagent, the clone, the fluorochrome, where we got it from, the catalogue number, whether we needed to titrate it or whether we used the manufacturer's recommended volume and so on. And if we have titrated the antibody, we then have the details about that in the template as well. Sometimes it's not entirely straightforward. Again, it's an area that sounds very easy, but when I looked at our platelet glycoprotein assay, we actually don't have any internal negative controls. And also we have very few diagnoses to support the accuracy of our assay. So in order to make this assay work the way we were very happy with, we wanted to include an isotype control. And every now and then we repeat antibody titration. So here is an example of a person with a bleeding disorder and a loss of platelet glycoprotein expression. We have maybe a true bleeding disorder case like this once a year tops, even though we are a referral centre. So we always have a non-sensical antibody, which is our platelet glycoprotein assay CD30. So it's from the same supplier, it's the same fluorochrome, but we actually use an isoclonic instead of an isotype control, I suppose you could say. And so quite regularly we carry out a titration to make sure that we have a sort of stable performance of our reagents. So let's go back to the gating strategy. In my experience, this is the #1 cause of differences between analysts, and overall for any of our assays, the biggest reason for discrepancy between results is always the analyst end, and it usually relates to the gating strategy or somebody having a bad day and not seeing something. So quite often what we have learned by doing this very detailed validation procedure nowadays is quite often we've actually refined our gating strategy a lot more than what maybe we did 5 years ago. And we greatly helped by doing a fluorescence -1. For any in-house design assay, we always carry out an experiment and we set our gates accordingly so that we know where the negative and positive areas are. But of course, if we take an assay from something that's really well validated, etc., we might not do it. Right, so moving forward, the settings, how we optimize the setting for each and every assay is stated. Most of the time we have what we call the general optimized settings. They're true for pretty much most assays, but some assays, like the platelet glycoprotein and a few others, have different individual cytometer settings. What's the robustness? Because even if we have cytometer settings that are very optimized and we're happy with them, we all know that when we get a new antibody lot, we might not be aware that we have a new lot, but all of a sudden we look at the data and it looks a bit wonky, right? So the compensation is a little bit not perfect, shall we say. And one thing I do like to do with particularly the type of result where my medium fluorescence intensity is very important. You know, a small change can have a big effect in my clinical readout of the assay. Well, then I take data and I do offline compensation. I change the compensation percentage value and I see how it affects the plots. Here are just some old examples, CD19 versus CD5, and if I artificially increase the compensation applied, you can see how we get more and more cells that look CD5 positive, but you can clearly see it looks not ideally compensated. It takes a very short time to do, but I like the idea of knowing that even if my compensation is well out of whack, even if my compensation is not correct, go, for example, 3.7 up here, to 6.5 there, it doesn't really change my readout. Here is another example from the BALL assay, CD38 versus CD10. It's the same principle. How much do my cell population move? How much does the MFI change if the compensation is incorrect? It's just for that awareness. And at this point, near the stage where you have to say, I've done enough validation. We have optimized the cytometer for the assay, we have optimized the assay itself, we have described it, we know the sample processing, we know the gating protocol, etc. We're going to lock it down to big. Now, actually move to validation, right? So now is the time to look at our limit of blank, our limit of detection, our precision. Now, of course, if doing this next section now, we find out that the precision data shows CVs of 30%, 40%, then clearly I have to go back. I have to unlock the assay, so to speak, and improve it. Usually it means making the gating protocol better. Or if there's any other issue found that we cannot accept. But in theory, we have now locked down the assay. So we need to see the analytical accuracy, and that normally would be comparing our new assay with the previous one we had in-house. But we can also compare with another centres, and we can also compare using EQA samples. And if there is no previous assay at all, we use diagnostic accuracy, so we can calculate the sensitivity and specificity. So the limit of blank, it's not something that we need for all assays. For example, our what we call the initial screen, so our assay to detect lymphoproliferative disorders in blood, we don't need LOB for that. But for our B-ALL, for our PNH, for our Sézary, or our multiple myeloma, MRD assay, for example, all these need to have an established limit of blank. We have a CAR-T19 assay, and we have an LOB for that one as well. But like I said, not all of them need that. Limit of blank is quite easy because we almost always will have samples that we know are free from disease. The H62 advises 5 samples. I'm not clear on why, but they suggest that each sample can be acquired 5 times. This is one of the areas where perhaps the person don't agree entirely with the H62, and I'm happy to talk more about that after the talk or at any other platform if you like. And one other thing where LOB can become a bit tricky is actually when you have an assay where you don't necessarily have a single phenotype that you look for. Let's take the Sézary as an example. For Sézary, there is one very typical phenotype, and it is 3 positive, 4 positive, 7 negative, and 26 negative or weak positive T cells, right? Quite easy. Until you start to look at things, and of course, some Sézary are positive. Many of them are 3 weaker. Some are PD1 positive, 26 positive. You end up having lots of